Okay, good morning, everyone. I'm Dr. Divya Ramyead, and today I'll be presenting on an overview of tympanic membrane retraction pockets. So what is a retraction pocket? A retraction pocket is a localized area of tympanic membrane invagination into the tympanic cavity. An atlantic membrane, on the other hand, refers to medial displacement of the whole tympanic membrane from collapse from its normal position. If one looks at the image on the right, you can see labeled A is a pars tensa, labeled B is a pars flaccida, and labeled C is a retracted tympanic membrane. The tympanic membrane is derived from three germ layers: the ectodermal layer, the mesodermal layer, and the endodermal layer. The difference in the pars tensa and the pars flaccida lies in the fibrous layer. In the pars flaccida, there's scanty and sparse collagen fibers in the fibrous layer compared to the pars tensa that has radial fibers as well as circular fibers. In the retracted tympanic membrane, there's a localized area of sparse collagen and fibroblasts in the fibrous layer. One must note that the most common site of retraction in the pars tensa is the posterior superior part, as this lax circular fibrous layer is more vascularized and is vulnerable to inflammation. The pars flaccida is the weakest part of the tympanic membrane due to the sparsity of fibers in the lamina propria and the direct insertion of the ectoderm to the scutum. Before we delve into the pathophysiology of retraction pockets, one must have an understanding of the middle ear ventilation anatomy. The tympanic diaphragm divides the middle ear into two compartments: the anterior inferior compartment and the posterior superior compartment. The anterior inferior compartment consists of the protympanum, the mesotympanum, the hypotympanum, the inferior part of the retrotympanum, and the lower unit of Prusak space. This space is ventilated by the eustachian tube. The posterior superior compartment, on the other hand, consists of the upper unit of the attic and mastoid air cells, and this receives ventilation from the tympanic isthmus. The image on the left here shows how the tympanic membrane, which is blue in color, divides the middle ear into the anterior inferior compartment, receiving ventilation from the eustachian tube, and the posterior superior compartment. As you can see, the posterior superior compartment is lined by a mucosal layer, and this is the part that helps in middle ear ventilation. The image on the right here shows how the tympanic membrane consists of bones and ligaments, and specifically shows how the tympanic isthmus is divided into an anterior and posterior part by the medial incudal fold. Any disruption in this or blockage in these ventilation pathways would lead to middle ear dysventilation syndromes. That is of two types. There's the global and selective part. The global middle ear dysventilation syndrome consists of failure of macroventilation due to tubal dysfunction, and they manifest as secretory otitis media, atelectasis, or adhesive otitis media. On the other hand, the selective middle ear dysventilation syndrome occurs when there is a blockage of the microventilation pathway with selective compartment hypoventilation, and this results in a focal retraction of tympanic membrane, which may progress even though there is adequate aeration in the rest of the middle ear cavity. Blockage of the tympanic isthmus and a complete tensor tympani fold would result in complete isolation of the epitympanum from the mesotympanum. And understanding these ventilation pathways also helps to reduce recurrence of retraction and cholesteatoma when we attempt to remove the cog and excise the tensor tympani fold through an anterior tympanotomy in order to open the anterior route of ventilation. The eustachian tube has a big role to play in the pathogenesis of retraction pockets. Failed ventilation, either from a dysfunctional eustachian tube or recurrent OME, acute otitis media, and abnormal gas exchange, leads to a negative middle ear pressure, resulting in loss of lamina propria and retraction. It is found that the patulous eustachian tube in habitual sniffers, they tend to have repetitive, prolonged negative pressure, precipitating chronic otitis media and retraction pocket formation. Otitis media with effusion also has a role to play. Otitis media results in histological degeneration and atrophy of the lamina propria of the tympanic membrane. It has been found that one has observed pepsin and Helicobacter pylori in the middle ear fluid. Inflammatory mediators are also found in adenoidal tissue and eustachian tube, as well as middle ear in atopic individuals. Looking at a paper on the pathogenesis of retraction pocket of the tympanic membrane, 31 past tensor retractions were analyzed histologically and immunohistochemically. The inflammation led to hypervascularization, destruction of collagen, and elastic fibers, especially in the pars tensa. The tympanic membrane was noted to be flexible and less resistant to negative pressure in middle ear in children with dysfunctional eustachian tube, and therefore prevention of inflammation is considered to be an important strategy in retraction pocket management. Looking at the classification of retraction pockets, there are three classifications: the TOS classification for pars flaccida, SADE classification, and the Caracon classification. The Caracon classification is a newer classification highlighting retraction pockets visibility and self-cleaning ability. It is staged into three parts. The first stage is a mobile retraction pocket. The second stage is a fixed pocket where the fundus is visible. And the third stage is a fixed retraction pocket where the fundus is not visible. SADE classification for pars tensa is graded into 5. Grade 1 is slight retraction of the pars tensa. Grade 2 is retraction onto the incutestapedial joint. Grade 3 is retraction onto the promontory, but not adherent to it. Grade 4 is a retraction of the pars tensa onto the promontory, but adherent. And grade 5 is associated with perforation. Looking at the TOS classification for pars flaccida, type 1 is a retracted pars flaccida. Type 2 is a retracted pars flaccida touching the head of malleus. Type 3 is one where the end of the pocket cannot be visible. And type 4 is associated with scutal erosion. The clinical picture of a retraction pocket varies from being asymptomatic to otalgia, conductive hearing loss, recurrent ear discharge, and dizziness. Looking at the diagnosis and investigations for a retraction pocket, this depends on the history and physical examination. One must take a proper otological and nasal symptom in history, find if there's allergy, and examine the ear, nose, and nasopharynx. One must then examine under the microscope and thoroughly clean cerumen and debris that can be found in retraction pocket to find what is hidden behind. One can also make use of the endoscope in order to appreciate the extent of the retraction pocket. A pneumatic otoscope is vital in order to establish whether the retraction pocket is reversible. One can also perform the Valsalva maneuver in order to inflate the middle ear. Audiometry will help us to decide on the airborne gap, which I'll come to later, which will help us in decision and treatment making. The tympanometry is also vital to help us ascertain if there is a middle ear fluid. Regarding evaluation of retraction pockets, the following points must be taken into mind. The location of the retraction pocket, if it's in the pars tensa, pars flaccida, what quadrant is involved, and what percentage of tympanic membrane is involved. It depends on the adherence of the pars tensa and flaccida. It depends on the external auditory canal status. If there's skin suffering, which I'll show you later, if there's granulation tissue, bony erosion, or otorrhea. It also depends on the depth of retraction pocket, if it is a self-cleaning pocket or not, if there's crusting, debris, and if the neck is widely open or constricted. It also depends on the osculus status, whether the tympanic membrane is in contact with the ossicles and promontory, and whether there are visible erosion of ossicles. The associated pathology should also be noted, which includes crusting, keratin retention, granulation, and bone erosion. So let us have a look at some clinical descriptions of retraction pockets. The image on the right here shows an otoendoscopy of the right ear with attic retraction of the pocket, a large open neck of the retraction. One can note deposition of debris in the depths of the pocket and notice skin suffering as labeled by the white arrow. The image on the left here shows an otoendoscopy of the right ear showing an attic retraction pocket and spontaneous atticotomy. You can see the bony erosion of the scutum. There's a lot of inflammatory skin canal, which is referred to as suffering, and evident sign of aggressive behavior of this retraction pocket. The image on the left here shows an otoendoscopy of the right ear with a more or less of the same degree of attic retraction, but without skin suffering. So why is it important for us to manage retraction pockets and have a close follow-up on them? While an untreated retraction pocket may remain unchanged or show spontaneous resolution, the rest progress and lead to three complications, either cholesteatoma formation, ossicular necrosis, or adhesive otitis media. The image on the right here shows an attic pocket that has transformed into a cholesteatoma. Helping us in decision-making is a CT scan. This helps to localize the retraction pocket and assess its extension in the middle ear. It helps us to ascertain the status of ossicular chain and middle ear compartments. In terms of a post-tensor retraction pocket, the CT scan shows extent of lysis of the incutostapedial joint. In terms of a post-flaccida retraction pocket, the CT scan will enable us to make an early diagnosis of bony erosion of scutum, which is a sign of an active pocket. The pneumatization status, as well as the aeration status of the middle ear, can be ascertained, as well as we can evaluate the AAA view. The image on the left here shows the labeled A1, the anterior epitympanic recess, between A1 and A2, the attic, and between A2 and A3, the antrum. The image on the right here shows scutum erosion. The arrows show evidence of soft tissue opacification, and the star shows an post-flaccida retraction. Now, the management broadly consists of the following: observation, medical therapy, behavior modification in sniffers, ventilation tube, tympanoplasty with cartilage reinforcement, and canal wall up mastoidectomy with or without tympanoplasty. Now, before we delve into which management to undertake, one must have the following 5 questions in mind. Whether one can wait or act now, will a cholesteatoma evolve? Will the hearing get better or worse? Are we helping the patient? And which pocket needs surgery? To help us in decision making, here are the following points that one must take into mind. The anatomical status of the retraction pocket, whether it's found in the pars tensa or in the pars flaccida. As a pars flaccida retraction pocket tends to develop quicker into cholesteatoma. Whether it's a controllable or uncontrollable retraction pocket, and this will depend on whether we can see the full extent of the pocket under microscope, and whether it is a mobile or fixed retraction pocket. It will also depend on the functional status of the ear, whether there is an air-bone gap greater than 20 decibels. It also depends on the presence of otitis media with effusion, which will give us proof of an active process in the middle ear. It also depends on the behavior of the retraction pocket. If there is rapid progression, adhesions, or cholesteatoma, this would mean one must act. And it also depends on the status of the other ear. So in infants and young children, one is more likely to find bilateral ear with similar findings. Contrary to teenagers and adults, where a normal other ear may allow the surgeon as well as the patient to take a more risky approach, whether acting conservatively or by surgery. While if the other ear is similar or worse, one would be more conservative in approach. Having a look at watchful observation. Watchful observation is best to take if there is no active inflammation, skin reaction in the external auditory canal, if there's no otorrhea, and if there's no significant functional deficit, that is a conductive hearing loss of less than 20 decibels. If the CT scan shows a well-aerated AAA space, this would mean that the retraction pocket is stabilized. Quite controversial, but medical therapies, some surgeons opt for medical therapies, including nasal decongestants, oral antihistamines, steroids, and inflation devices in the aim to improve the eustachian tube dysfunction. However, there are articles in literature that negate their benefits. Now, to support the watchful waiting policy, a paper in 2021 by Rumi analyzed 81 years. The median duration of follow-up was 64 months, which is roughly around 3 years. A mean improvement in hearing was found to be 2.4 decibels. It was observed that a SADE grade 3 had poorer outcomes in terms of audiometry compared to a SADE grade 1. And in conclusion, it was found that the otoscopic findings and audiometric results remained stable in most patients with tympanic membrane retractions without treatment. Roughly, based on the Karakon classification, one can have the following steps of management. For stage 1, which means a mobile retraction pocket, one can wait and see and follow up the patient every 3 months. The indications of surgery in this stage would be if there's a hearing loss greater than 20 decibels in air-bone gap, if there is a presence of chronic middle ear effusion, and if there's progression of the retraction pocket over time. The types of surgery one can undertake would include a tympanostomy tube placement for the active middle otitis media with effusion and excision of the retraction pocket. For stage 2, which is a fixed and controllable retraction pocket, one can wait and see, and if after 3 months there's no progression, continue the watchful waiting policy. Indications for surgery would, however, need to be considered if there are clinical features of keratin debris collection, otorrhea, skin suffering, granulation tissue, and an invisible bottom of the retraction pocket, if there's a conductive hearing loss of an air-bone gap of 20 decibels or more, and if CT scan findings show erosion of the scutum and opacification in the anterior epitympanic recess and the AAA spaces. The type of surgery one can then undertake includes cartilage tympanoplasty with or without a T-tube, canal wall up or down mastoidectomy, and an atticotomy depending on the extent of disease. Regarding stage 3, which is a fixed and uncontrollable retraction pocket, surgery should be performed to prevent cholesteatoma formation. To aid in treatment, a temporal bone CT scan should be done, and the types of surgery again include cartilage tympanoplasty and tympanomastoidectomy with or without ossicular reconstruction. Pediatric retractions are different in the sense that the pars tensa retraction tends to be more prevalent in children, while pars flaccida retractions are more prevalent in adults. In a study analyzing moderate and severe tympanic membrane retractions in children and adults, it was found that some authors recommended adenoidectomy as first-line treatment for children aged 4 to 8 years, irrespective of the adenoid size. However, adenoidectomy has reported outcomes are inconsistent in literature, and improvement is statistically non-significant. To add to controversies, eustachian tube dilation has gained popularity lately. However, there's not enough high-level evidence to support its outcome and safety. This is a paper that aimed to look at cartilage tympanoplasty in the management of tympanic membrane atelectasis, whether or not a ventilation tube is necessary. It has been found among otologists that cartilage and perichondrium composite graft with concomitant placement of ventilation tube is a common practice to reverse atelectasis and repneumatize the middle ear. In this study, 46 patients were divided into two groups, one who had reconstruction with the T-tube and one group without the T-tube. And it was found that there was no benefit with the ventilation tube insertion compared to cartilage tympanoplasty alone, both in hearing outcomes as well as in post-operative airborne gap averages. Therefore, the main question we ask ourselves is, can retraction pocket treatment prevent progression? Although most clinicians support initial conservative approach, there's no clear cutoff regarding when and which surgical solution should be offered. Retraction pockets tend to recur at an average rate of 35% in cases of simple excision. In terms of the natural history, 10 to 16% of grade 3 and 4 retractions progress to form cholesteatoma. There is currently no high-quality evidence regarding their effectiveness in terms of disease progression, hearing outcome, and recurrence rate. A randomized controlled trial by Barbara revealed no statistical benefit of cartilage tympanoplasty compared to the wait and watch approach in terms of progression of retraction pockets. And some argue that the surgical therapy could benefit. It is invasive and is associated with risk of peri and post-operative risk. Nevertheless, the search is still ongoing. Novel surgical techniques include glue tympanoplasty, which is carried out under local anesthesia. The retraction pocket is lateralized and lifted out with suction, and fibrin glue is applied over the tympanic membrane surface. Endoscopic laser tympanoplasty is also being carried out in Europe in outpatient department setting using KTP laser. The principle behind is the laser beam contracts the tympanic membrane, heats the collagen fibers, leading to their fusion and remodeling. And there's the design of microendoscopes to pass through grommets in order to view middle ear ventilation that is also underway. That being said, in conclusion, the main aim in treating an ear with a retraction pocket is safety of the ear. There are no hard and fast rules as to how to manage an ear, and therefore one must take all the variables, as I mentioned earlier, and tailor the decision for the patient. Thank you for your kind attention. Are there any questions? Prof. Harris, would you like to comment?
Thank you, Divya. That was a very comprehensive presentation. And I think you've highlighted nicely that these are fairly controversial. And I think as ENTs, one of the problems is that we are at risk of over managing these patients. Just to highlight once again, as you've mentioned in your presentation, that it's very much a retrospective diagnosis as to what retraction pockets are stable and which ones are progressive. So the question is really how frequently you follow them up and how long to follow them up for. And there's no hard and fast rule. 3 months in a busy outpatient setting is probably quite a lot for a retraction pocket that's grade 1. So we usually do it every 4 to 6 months, which I think is fine, unless you worry that this retraction pocket is progressing quite rapidly. I think as you've said in your presentation, the minute you see granulation tissue or crusting or retention of keratin or the hearing loss is deteriorating, that's an indication to actually operate. Just in terms of the surgery, I'd be very wary of using KTP laser in an ear with a retraction pocket. We use laser to do stapedotomy. You know, that retraction pocket the tympanic membrane is incredibly thin. And if you've got facial nerve or stapes foot plate or the round window, I'd be very cautious. I've not personally used KTP laser. I mean, there's lots of different tools you can use, but at the end of the day, one has to be safe. I think one of those articles that you actually, where you mentioned KTP laser, has actually found that safety is a big issue when using laser. And the most commonly performed is for retraction pockets is really the cartilage reinforcement. And that's just to try and prevent cholesteatoma. Having said that, I've had patients who've progressed to cholesteatoma in spite of. And the problem really is that you never know which of those patients that you operate or which ones you manage conservatively are going to progress or not. So it's an incredibly interesting topic and one that's actually, yeah, quite controversial if you look at the literature. But that was a very nice presentation. Thanks.
Thank you, Prof. Are there any other comments from the floor? Okay, thank you for your kind attention. We'll end the meeting and we'll have a meeting on Friday. Have a nice day.